Have you heard about FDA-approved Vyvgart Hytrulo, efgartigimod alpha, and hyaluronidase QVFC for subcutaneous injection? Visit vyvgarthcp.com to discover clinical trial data and explore patient profiles. Vyvgart is a registered trademark of argenx. Vyvgart Hytrulo is a trademark of argenx.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. Today, I have the pleasure of speaking with Messoud Ashina. Professor Ashina is a senior scientist at the Denmark Headache Center in Copenhagen and is one of our most popular regulars in headache medicine. We invited him on to discuss his work as senior author on a paper just published in Neurology called Differences in Cortical Morphology in People with and Without Migraine, a registry for migraine MRI study. Congratulations on your paper.
Thank you so much.
So let's start out with the purpose of your study.
When we talk about the migraine, we usually hear that the migraine is an invisible disease. You cannot really take a blood test. You cannot do the imaging to diagnose a migraine. We diagnose migraine purely based on the clinical classification, the criteria. And there is always discussion or a debate about the possible biomarkers. It could be a blood-based biomarkers, but there are also imaging-based biomarkers. It's an ongoing quest to reach this goal, to show something which we can call a biomarker of disease. Why it's important? Because then when you treat the patients, you can see whether this treatment is a disease modifiable or not disease modifiable. So that's why it is an interesting topic. And this study, the background was about the structural imaging, just to see whether we can see anything in the cortical morphometry of migraine, which may say something about adaptation to recurring headache episodes that the people usually with migraine experience. And that's why they're coming to the clinical practice to see us neurologists. So this study, we focused on the cortical morphometry, and we did it by comparing the large sample of people with migraine and healthy controls. In addition, we also looked across the migraine subtypes. We tried to cover the whole spectrum of migraine.
I agree. Migraine is a clinical diagnosis. There has been studies looking at structural differences in people with migraine. And so what does the background study reveal?
Several, but small MRI studies, they looked at the cortical features that differentiate people with and without migraine. We also know about the MRI studies that they specifically focus on the cortical differences between subtypes of migraine, even phases of migraine, and also symptomatic hemispheres, meaning that in some individuals you have a left side or right side migraine, just to see whether laterality can also be reflected by the morphological changes. But these studies reported a very different, various cortical changes. And they suggested a multiple region across the nail, which included, just an example, somatosensory cortex, the temporal and occipital areas. But the reported changes, these studies, I would say, they have one problem. There is overall problem with MRI finding, a so-called, reproducibility problem. It's very difficult to reproduce other findings from other groups. And this goes to the methods that we applied, the way we apply statistics, and also the patient material, that the people with migraine included in studies. What was suggested that these cortical changes, they maybe just reflect kind of a genetic susceptibility of migraine, or just reflect the plasticity of the brain because of this repetitive head pain, nociceptive activation, and also causing a kind of a reactive degliosis. We have some methodological reservations about those studies, primarily because of the sample size and reproducibility problem, of course.
And I know you specifically looked at surface area, thickness, and volume.
Yes. So in this study, we looked at the cortical morphometry and we analyzed the differences between the distinct migraine subtypes. We know the migraine with and without aura, chronic migraine is a complication of migraine, and also tried to look whether there is any also correlation during the acute migraine attack. And so this, we tried to explore whether these alterations can also correlate with some of the most important clinical features of migraine. So this is a pretty large study in terms of the sample size, and also applying a very rigorous and very conservative methodology, specifically in terms of the statistics. We try to do everything which we can say a state of the art in terms of the statistic when we have MRI data.
As you say, a very large study and also a very clinically detailed study because you looked at aura status, you looked at migraine frequency or headache frequency and presence of medication overuse. So can you tell us a little bit about differences based on these clinical parameters?
Yes, it is a quite large study. It's included 296 participants with migraine and also 100 healthy controls. So it's a quite impressive sample size. And among the participants with migraine, we had more than 60% of people with migraine reporting chronic migraine. We had also people reporting migraine with aura, approximately 35%. And also about 30%, they experienced a migraine headache during the scan sessions. So we tried to cover the whole spectrum, and that's why it was important when we looked at the different comparisons. If we take the first one, just comparing the brain of people with migraine with healthy volunteers with no history of migraine was the first thing that we did. So what we found that with the participants with migraine, they showed less cortical surface area on what we call on the left anterior insula. And that was compared to the healthy controls. So this is the main find. Then we start looking at the subgroup of people. First of all, the chronic migraine. Why chronic migraine? Because we know that the chronic migraine represents typical population of people with migraine in the specialized centers. And what we found that those people with chronic migraine, they exhibited less surface area, again, of the left anterior insula and larger surface area of the right caudal anterior cingulate cortex. We usually see in the literature the abbreviation ACC, this area. And again, compared to the healthy volunteers. And in this case, it's also important that we looked at the subgroups of people with migraine with aura, ictal, episodic, headache-free, and we didn't find any differences, when we compare them to the healthy volunteers in the cortical surface area, thickness, and volume. So that was overall the difference specifically for the chronic migraine. Then another interesting finding, because as you said that some of the people, they also took preventive medications. What we found that the participants who used preventive medications, they had a greater surface area and volume of the right inferior parietal cortex and adjoining occipital cortex. And that was, again, compared with the participants not using preventive medications. Even further, we know that the many people we see in the clinical practice, again, they also report the medication overuse headache. We look specifically on the participants with medication overuse headache, and we found that they had a smaller surface area of the left lingual and postcentral gyrus, and that was compared with the participants without medication overuse headache. So, and later we also looked at the differences between the chronic and episodic migraine with aura and without aura, and also the people reported head pain, the ictal state, compared to the people without headache, completely headache-free on the scan session. We didn't find differences between the two groups. So this is the most robust support to the hypothesis that many have, saying that the region which are specific, the cortical involvement in migraine pathogenesis, and these regions with potential importance of insula and ACC, specifically in migraine. Basically, if we can say overall, so they're all related to the pain, let's say, the structures associated in pain processing regions of the cortex. Okay, so those changes. Apparently, they are associated with the headache frequency because we show in chronic migraine. And I think that these findings, they have also some kind of, let's say, future therapeutic implications. Why? Because we know that we use a headache frequency as an outcome measure when we try to address the question whether the drugs that we use now, specifically the targeted therapy, but also non-targeted therapies, they may change something in the people's brain when we treat them effectively or not effectively. So this is very important and opens up the future investigation when we can look at in the longitudinal design what kind of these structural alterations can also correlate with the clinical measures, the treatment response. I'm particularly interested in the sensitivity to the migraine-inducing triggers. We can correlate maybe with that. Or also, we can also do it with the correlation of the treatment response. So in fact, Tesha, we have this data, but we haven't processed yet. So we will have in the same material some of the people who received the targeted therapy over the 6 months, and then we will see whether we can cause some kind of changes in the morphology and brain if the treatment is successful, and compared to the people that were not really responding to these targeted therapies. So I can disclose that was monoclonal antibodies against CGRP. So very interesting prospect to look at in the future. So I think that by the end of the year, we're probably going to be done with this data and hopefully submit.
So just moving back a little bit about prevention and changes associated with preventive therapies versus medication overuse headache, different patient populations possibly. And so what can we say about the potential of protective factors on people with preventive therapies?
There are two aspects here. As you pointed out, one is medication overuse, another one is prevention. Okay, so let's put that way. When we see these differences, the people taking prevention and people not taking prevention, we need to explain these differences. Because when we see, again, morphological changes, the interpretation of these changes is very difficult. And because it is a cross-sectional now, you compare patients against healthy volunteers, it is difficult to say the impact of these findings. But again, I'm taking you to the future. When we look at the treatment, then we will see how much it means. And then we can hypothesize that by giving the drugs as early as possible, especially for people who are eligible for the treatment, we might prevent some plasticity, some in a negative fashion, some plasticity changes in the brain if we treat people. And as a clinician perfectly well, that we have so many migraine people undertreated, not only underdiagnosed, but also undertreated. We know that they're eligible for the prevention, but they are not receiving the prevention. So maybe this kind of studies that we are representing today and the future studies in the longitudinal data will address this question and kind of be also part to stimulate the field just to make sure that we can actually do something. And when we do something, we can also cause changes in the brain in the positive fashion, in the positive direction. And as I said, that seems that it correlates to the frequency. And the second point is that, as you mentioned, was medication overuse. We know that the medication overuse, it's one of the also complications of migraine. And people with migraine not taking these medications for fun, they're taking because they suffer, because they have so many attacks. And by giving them effective prevention, we can prevent the medication overuse. And if we can again show something in the brain of the people with migraine to show that it can go again, we can reverse these changes. Let's say assume that those changes are negative and we can reverse them by preventing the medication overuse because we treat them with effective medicine in the longitudinal studies that I mentioned before. Then it also important message to the researchers, but also to the clinicians that it is important to diagnose and treat these people. And I would like to emphasize here that having targeted therapies together with these findings, it is another statement that the migraine has a biological foundation, neurobiology behind this disease. And actually, we can do something about that by treating them with these medications.
So it seems like the main limitation of the study is, as you already mentioned, the cross-sectional nature of the study. And maybe it would have been nice to look a little bit more at comorbidities of patients, maybe with comorbid depression, some factors that we think increase the burden of migraine.
We corrected for this one, and we didn't find any relations, to this. But the findings that you see, they've been through a very rigorous and extremely conservative statistics. And those positive findings which survive these statistics. And you know that we are very conservative here in Copenhagen in terms of this methodology. So we try to do our best to provide robust findings, But what we can see here that this findings suggest persistent cortical changes that which associated with a migraine, and they are limited to these specific pain processing regions that I mentioned before, the insula and caudal anterior cingulate gyrus. And what is important, again, seems to be related to the chronic migraine. So it is important passage here. But of course, you're absolutely right. Limitation is that it is a cross-sectional, and that's why I'm telling you, promise you, that we will come up with a longitudinal data and we will see. And another good news is it's not only cortical morphometry we're talking about here. We're also talking about very interesting findings that I can assure you that will come very soon about the inflammatory markers in the brain and also functional MRI status. So we will see some interesting data in this cross-sectional material, but then the functional, structural, and also inflammatory markers that we try to address in the longitudinal phase design. The same group of people, okay?
We like to think of migraine as more than a pain disorder, and there are multiple other associated symptoms. And I would say the insula would also cover some of those perceptions of sound disturbances and light disturbances as well. Were you surprised that the changes were limited to some of these areas?
Working for some years with imaging, there are many, let's say, critical aspects of methodology of imaging. It's very easy to find many positive things. And that's why we really tried hard. I'm not saying that this is the best of the best. No, I'm sure that people will do much better studies in the future. But at least we try to be very conservative in terms of statistics and methodology applied here. And in fact, that this is what we get in terms of the structure. I cannot disclose you about the functional data yet, and not inflammation that we also try to address. But what I can say that the brain is quite complex, and we know the brain is a major processing organ, receiving many inputs from all around of our body. And when you experience migraine attacks, and of course, it will affect your brain. And it will affect the different regions of the brain. The question is that whether they're specific for migraine or not specific for migraine. Okay, maybe you can also see it with a low back pain. Maybe you can also see it with other kind of pain. Or you can also see in people with a different psychiatric disorders such as anxiety and depression, etc. Some of the areas, they have something to do also with the emotional aspect. They're also an important part of the limbic system, which also important for the perception of the pain, our experience of the pain, as you said, including some of the central features of migraine, as you mentioned, photophobia, could be also phonophobia, could be also other symptoms that we usually experience during the migraine attacks. So I think that we are on the right track in my group, in my lab, and we're trying to address the brain plasticity, the importance of the mechanisms underlying migraine in context to brain using the imaging. And this is the only way we can actually address this question because they provide us non-invasive method to address important research questions. The only thing which is important is that, again, methodology and kind of consensus across the different research groups. So we do things in the same way, in the same manner. This will provide robust data in terms of reproducibility, but also provide us opportunity maybe in the future to pull data together. And if we can do that, we can increase the sample size substantially. And maybe in the future, we can also apply artificial intelligence just to run this material and tell us which brain is different from another brain and why it's different. So that will be something we can do it in the future.
And so you started off this conversation talking about this approach as an imaging biomarker. So what are your thoughts? Are you sold? More work needs to be done?
I think more work needs to be done. And I think that imaging is still there. It is alive, and we need to use imaging to address very important questions, underlying questions on migraine pathophysiology, pathogenesis. And I believe in the imaging biomarkers. But I only think that, as I said, that we need to be very careful in terms of methodology, make sure that we can reproduce the data and pre-register our status with a clear hypothesis and come up with some data which might help us to explain migraine as a disease. But also the most important thing is also whether we can also apply to see whether, if these changes are really specific for migraine, whether we can modulate, we can change that in the course of the treatment. And then this might also lead something in the future to apply the imaging, in the precision medicine, but not alone, in combination with other biomarkers. So just one example, the blood-based biomarkers, to find something really robust and reproducible, then we can combine the multiple biomarkers, again, the avenue toward the precision medicine, when we can tailor the treatment, and we can see the changes in the brain in the course of the treatment.
Excellent. Well, thank you so much. And again, congratulations on your paper.
Thank you, Tesha.
This is Tesha Monteith with the Neurology Podcast. Be sure to check out the paper just published in Neurology, and thank you for listening.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.